Hello, everyone. I'm Jody Hoyos, CEO of the Prevent Cancer Foundation. It is such an honor to welcome all of you to the 21st Annual Quantitative Imaging Workshop, hosted by the Prevent Cancer Foundation and presented in partnership with the American Lung Association. Whether this is your first workshop or your 21st, I thank you for not only joining us, but for committing to the exploration of new ideas to increase lung cancer screening, early detection, and better health outcomes. As we know, lung cancer screening rates are the lowest of all routine cancer screenings. By discussing new opportunities to optimize screening and increase access, we're getting one step closer to getting more people screened, improving accuracy, and better managing lung diseases. Before we begin today, I'd like to say a few thank yous to the team who works year-round to bring this workshop to life. First, our steering committee, who each take time away from their lives and their day jobs to make this event possible. This is an incredibly dedicated group of individuals. I'd like to thank Dr. Jim Molshine, the leader of this group, who is also the scientific director of the Prevent Cancer Foundation. Also on the committee, we have Prevent Cancer Foundation's founder, Bo Aldeje, Rick Avila, Raul San Jose Estepar, Anita McLaughlin, Bruce Pyenson, Al Rizzo, David Yankolovich, Matt Cham, and Mary Pasquinelli. Thank you to each of you for the role you play in facilitating this valuable exchange of ideas. I'd also like to thank our talented and dedicated staff who keep things all on track and ensure the success of this event. Special thanks to our Senior Manager of Community Education and Conference Planning, Adrian Harkness, as well as Erica Childs-Warner, Jennifer Niangoda, Tara Williams, Kira Meister, and Sophia Matthews. I also want to extend a sincere thanks to our external meeting coordinator, Liz Hall, and our AV partners, Blue Ridge. And of course, I'd like to thank our generous sponsors whose support makes this event possible. We'd like to express our gratitude to the American Lung Association, our longtime partner of the workshop, for their support. And thank you to our gold sponsor, AstraZeneca, our silver sponsor, Lilly, and our bronze sponsor, GoTo for Lung Cancer. We encourage you to use the chat function throughout the meeting, interact with one another, exchange ideas. Please stay in touch with us after the workshop as well. Visit preventcancer.org and sign up for one of our newsletters and keep in touch with the latest news in cancer prevention and early detection. You can also find us on social media at Prevent Cancer. With that, it is now my pleasure to introduce Dr. Jim Molshine to kick off today's program. Dr. Molshine is a professor of Rush University at Rush University, where he has served as Associate Provost and Vice President for Research, as well as Acting Dean of the Graduate College. Prior to joining Rush University, Dr. Molshine was at the National Cancer Institute for 25 years, where he served on the research faculty. Dr. Molshine's enthusiasm and commitment to enhancing public health across all populations is truly infectious, and we are very grateful to have him as part of our team here. Please welcome Dr. Jim Molshine.
Jody, thank you for your very generous comments. Thank you all for being here and for all you put into bringing forward our conversations today. And I have a couple of slides that I want to use to give a brief overview. This is a different kind of interaction. This is a workshop, and this is hopefully a working workshop in which we benefit from the participation of everybody involved in this effort. And in order to make this happen, I want to go briefly through what we're anticipating to be the thrust of our next 2 days in this effort to look at the quantitative imaging and the development of this very important public health service of chest imaging. And so if I could go to the next slide. I want to echo Jody's comments, thanking the steering committee and the staff that has helped us get here and have this presentation. But I'm also deeply honored by the support from the sponsors, because this is not like a typical CME or some of these other types of meetings. This is This is a area in which product development will happen, but it's not immediately developable at this point in time. We're going to hear about lots of innovative new ideas coming forward, but right now this is an effort to improve public health, which is kind of hard to sustain in today's effort, in today's world. And so we appreciate everybody who helped us make this possible today. Next slide. Now, this is the framework. The goals of this 21st workshop is very simple. We're trying to increase screening participation because we think it can save more lives. For a variety of reasons, for some length of time, we've been discussing that one of the problems in getting this kind of service out into the community more is how hard it is and how our structures inadvertently form barriers in terms of participation, and we'll be talking about those things. But the most important thing that has evolved, it was very evident last year and the last couple of years, increasingly so, is that screening works. We're getting reports from across the world that they're doing screening, they're doing it successfully, and that they're meeting or exceeding the kinds of mortality impacts that were reported with the major randomized trials of a decade ago. So if you have a service that works in the most lethal cancer on the world, and it's not getting out, I mean, what's the deal? So this is a very complex problem, and we want to pull it apart and think about how some of these innovations in imaging, computer sciences, the intersection can, and with the new tools with AI, can be woven together in an effective, efficient, economical way to bring this service across the globe to allow people to avoid the trauma of premature death. It's a very simple concept. So next slide. Here's the depth of what we're dealing with. This is actually data from our colleagues at the Lung Cancer ALA, in which they do a lung health barometer. And the most recent one, which is on their website, they find that only 38% of their respondents were familiar with the availability of lung screening. And I say this is in the wake of a heroic public relations campaign the American Lung Association has sponsored, that's been in every newspaper and on the side of buses all across the land. And I'm talking right now about the United States. This is an international meeting, and some countries are having similar problems. Some countries are doing much better, but not many. So I think all of us have a communications challenge, and we're going to talk about that. Next slide. If you don't believe the ALA, in JAMA, the JAMA network, this month, 10 days ago, they had a couple articles about lung cancer and lung cancer screening communications. And this is a slide from the group in South Carolina, which did a survey, and they found that of the people that they surveyed, you can read the histograms, a certain fraction have still never heard of it. But their point was that the vast majority of them had never heard of it from a medical professional, from a trusted authority. And in many things we do, we think that trusted voice is real important in decision making. Now, I didn't put a slide in, but in the same, JAMA network, there was also a kind of a secret shopper experiment in the beginning of the in which some group called a random sampling of hospitals from across the country and said, I want to refer a person for screening. Put me in touch with somebody at your system that can help me do that. That's successful 10% of the time. Unbelievable. Unbelievable. We're not talking about poison ivy. So we have some challenges. People do not believe this is the transformational kind of tool that we, I think it can be. So we're going to talk about how do we disrupt that. Next slide. Now, the federal agencies have been, they try their best to do right by the American citizens. But in the case of lung cancer screening, in our country, we have the reimbursement for payments for this done through this Medicaid agency, Center for Medicaid Services, Medicare and Medicare Services. And this is from their statement on their website in regard to lung cancer screening. And they say, we think we got to be very careful about this stuff because there's some real dangers associated with screening, and they include false positive rates. They include risk of overdiagnosis. They include excessive radiation exposure. Well, I'm sorry. If you use contemporary best practices that are widely adhered to in the screening community, the false positivity rate is not high, especially if you use quantitative imaging volumetrics. It's not high. The overdiagnosis rate, which was published by the National Cancer Institute in the 10-year follow-up to the NLST, as being, roughly 10%. That's not high in cancer screening. And it's even better now if you follow the program of the Netherlands group, the Nelson, they do even better with overdiagnosis. And the excess radiation, again, through sustained efforts, through all kinds of vendors and efforts with the metaphysics community, low dose T is done with a dose that's equivalent to what many of us encountered in the airplane when we flew to this venue. So the public safety issues have to be balanced with the importance of the tool itself. And I think that's right. Right now, that's out of balance, and we have to work with that. And one of the things that we have to disrupt this, next slide, please, is the fact that we have, over the last years now, been talking in this forum about when you do a thoracic CT, you get additional information about the thorax of those individuals who have smoked cigarettes for decades and have been at risk for related comorbidities that are well understood, including lung cancer, emphysema, COPD, and coronary artery disease. And coronary artery disease happens to be the leading cause of premature death in the world. And so we're going to be hearing from Dr. Oudkirk about his two efforts in which he's working with colleagues in the Netherlands and across Europe to look at the technique that they use for lung cancer screening applied for chest imaging for coronary calcium, and what the reliability of that is, and what are the performance constraints. And we'll hear that in a few minutes. Next slide. Next slide, please. So then after the plenary session, we will have an award session, which I thought I had a slide on.
There was, let's go back.
Did we skip a
Go
slide?
back one, we skipped.
I don't control it. Thank you. This is what I was looking for. After the plenary, we have this wonderful session in which we get to recognize the accomplishments of individuals who are making a profound difference in this world of lung cancer mortality. And this year we have the pleasure of having Dr. Nancy Obachowski with us. And we'll be doing that in a couple of minutes, and we'll spend more time on exploring that soon. Next slide. After the award presentation, we move right into the sessions in which we get into the meat of the workshop interaction. And so the first session, which will be led by Dr. Yankelevitz, is about basically the best practices with chest imaging. What are the things that we're seeing in the clinics now? How is that being reported? How are those reports being moved into clinical management. And then what's the regulatory environment influencing those things? These are complex, important issues, and David has assembled a wonderful group of experts to help that discussion. Next slide. Next, we'll move on into a very, very exciting area in which we're bringing artificial intelligence into this complex area to simplify it so it can be operationalized in a variety of different settings. This just does not happen with a snap of fingers. There's lots of issues underlying this, and Rick will help us walk through this again with a group of talented experts. Next slide. As this is a workshop, we will have some time for two different groups on different topics. One, kind of a clinical breakout we're calling on silos. And we're looking at how our healthcare system is deployed now and how well that suits kind of the patient-centric, screening-centric approach to an individual entering into screening to get care for across the spectrum of diseases that are induced by tobacco, that they could be affected, that are kind of running awry of the discipline specific way we tend to deliver our care. Now, in some other countries, it's approached in a much different way. We're going to talk about this example, and I think we'll learn things that'll be relevant across the world, but certainly we have a lot of work to fix these issues in the United States. And then we also want to focus on a second, more technical breakout that will explore some issues that we've been talking about for the last couple of years, but now we're thinking about how can we use these new imaging approaches for pulmonary parenchymal disease and move them into implementation now in terms of systematically evaluating the lungs in ways that allow for drug development and other agencies to preempt progression of COPD and related diseases, which again is the fourth leading cause of premature death in the world, across the world, and is, you know, I don't know how to discern what the difference is between a heart disease death versus a lung cancer death versus a COPD death. They're all terrible. They all intercept people early in life, relatively speaking. And we have an opportunity to potentially jump in on the basis of improved imaging at a much earlier stage in the disease in which reversibility of the lethality of these disorders can be achieved. And that's why we're here. Next slide. So we look forward to those two sessions. Then we move on after lunch into perspectives on the launch challenges, the implementation of screening. And we have Bruce Pyenson and Anita McLaughlin to help us from their perspectives, taking examples in which pharma has had challenges that are similar and understanding how they dissect these challenges and start thinking about solutions and do this kind of in a more efficient process than we typically pursue in the academic world. They'll also be gleaning the global implications of this because, again, this is not a US problem, this is a global problem. And there's opportunities for collaboration across the world. And then they will come to grips from their perspective on this intersection of cancer and cardiovascular disease. And maybe you can argue that it's not so important to get a lung cancer screening, and that's why 10 or 15% of the people in the country are doing it. But when you start putting together a screening tool that finds a state of disease for cardiovascular disease and lung cancer, in which very significant things can be done to preserve life, there's nothing else like that in medicine. And so we've got to start leveraging the real public health potential of this in a more serious dialogue with the medical community, regulatory community, and the public. And I think we'll be hearing more about that. Next slide. Okay, the next session will move into a little bit more about the technical details with AI and cardiovascular imaging. Because, this is stuff that is just emerging now, and there's a lot of innovation. And we fortunately had Matt Sham, who's an expert on cardiac imaging, to bring together a group of world-leading AI developers in the coronary space to tell us what they're doing and what they've seen and what they've experienced, why they're doing what they're doing, and potentially talk about collaborative efforts to bring forward, more fuller interactions to accelerate these processes for public health benefit. Next slide. Last but not least, the host for this organization, Prevent Cancer Foundation, American Lung Association, are both advocacy organizations. And at the end of the day, we love computer sciences. We love innovation. But what do patients think about this? What do people that are thinking about screening think about this? How are these efforts being received in the field? To do this, we have Mary Pesquinelli from our steering committee to lead the discussion about the kind of feedback that we're getting, what it means, and how we should be thinking about that as we put all this stuff together. Next slide. So a very important conversation. Next slide, please. So then we come back and we try to extract some reason from the chaos, okay? And we'll have a final breakout session, and my colleague and fearless leader, Carolyn Aldershay, will join me to have the final breakout discussion. And we'll try to think about actionable efforts that we can agree to that might be taken up over the next year or two to try to accelerate this process. Next slide. I think that's it. Oh, yeah. I just, this is a slide I used in an earlier meeting. This is a slide of Archimedes' concept of if I have a place to stand, I can move the world. We need a place to stand. And we will move the world. So it's kind of fun to think about.